also we live for
All right, good morning, good afternoon, good evening, everyone, wherever you are. We're really excited to welcome you to this webinar to explore systems thinking and how we can use that approach for accelerating early childhood development outcomes for young children all over the world. My name is Shekufe Zanji. I'm the Global Technical Lead with the Early Childhood Development Action Network, and it's a pleasure to welcome you to this webinar that's co-hosted with Harvard and MCRI. Before we start, just a few housekeeping things. All your questions, please encouraging you to put it in the Q&A. In the Q&A section, we'll leave the chat itself for your introduction. So why don't everyone just introduce themselves? Where are you calling in from today? What organization you're working with, and what is interesting about the systems approach for you, and why you're here and what brings you here today. But without further ado, I'm going to pass it over to Dr. Aisha Yousafzai from Harvard University to share with us her opening remarks for this webinar. Over to you, Aisha.
Hello, everyone, and it's a real pleasure to be able to join this webinar today. So in the ECD community and beyond, it is now widely recognized that in addition to health and nutrition inputs, young children need early learning opportunities, responsive caregiver-child interactions, and the prevention of violence in order to thrive. And the Nurturing Care Framework has provided us all with a multi-sectoral roadmap for action to scale these interventions and to promote early childhood development. We have robust evidence for the sorts of interventions that work to promote learning and development, to reduce violence, and to improve caregiver practices. However, these programs have yet to reach the millions of children who need them. Despite the enormity of the challenge, I believe we have many reasons to be optimistic. For example, in recent decades, we've seen national rollouts and investments of programs like Chile Crece Contigo or Grade R in South Africa, and more recently, Criança Feliz in Brazil. These tell us the scale of a nation's ambition to invest in its young children. And so the questions that we need to be asking as a program audience, a policy audience, and an academic audience is not what types of interventions work, but how do these interventions work? How can they be integrated into systems of scale to not only achieve the access that we desire, but also the equity, the quality, the impact, and crucially, the sustainability. In other words, the first question that we should be asking is, how do we design for systems? When we take an ECD intervention package, we recognize that no matter where in the world we're going to implement it and which system it's going to be implemented in, it will need to be adapted. So what are the non-negotiables in terms of the content, in terms of the delivery? What are those essential ingredients? And the second question we need to be asking is, what are the sorts of interventions that we need to do in the system itself to be able to help the system uptake and absorb those interventions, and to be able to improve the quality of those interventions over time and sustain them? For example, how do we promote ownership, community engagement, and demand for these interventions? How do we work with ministries of finance to protect the much needed resources? None of this can be done for free. How do we build the skills of, for example, community health workers or primary healthcare nurses who have been traditionally trained to deliver very different sorts of interventions, whether that's a vaccine program or a malaria prevention program? Different sorts of competencies are needed when it comes to promoting family functioning or mental health or caregiver-child interactions. How do we build that capacity within the system? And what do we need to inform us about the system's progress in terms of its readiness to absorb these interventions, and incrementally over time, How do we track that uptake, the improvement of quality, and the scalability of these interventions? One of the great things about the ECD community that I've always treasured is that we are very good at being able to collaborate across health, nutrition, social protection, education platforms. And this means that we can take lessons from the expertise and the experience of those that have already started working in systems to upscale, improve the quality and the delivery of interventions we know are essential for our communities. And so we don't need to start from scratch. And that's why I think today's webinar is very welcome, to be able to draw on those experiences, to be able to draw on those expertise and see how we can use them to strengthen what we want to achieve in the field of global early childhood development. And so I'm very excited and keen to learn from all of the presenters today and to learn from all of you and in today's discussion. Thank you.
Thank you so much, Aisha, for that lovely framing. And now I'll turn it over to Kate from NCRI for the brief overview of the work we've done in the past year.
Great. Thanks, Shakube and Aisha. As the first team member presenting from Australia, I'd like to acknowledge the traditional owners of the land that are part of the teams joining from, the Wurundjeri people of the Kulin Nation, and pay our respects to elders past, present and emerging, as well as any First Nations people joining from elsewhere today. Aisha's already beautifully described many aspects of the rationale for exploring the role of systems thinking in ECD. I'd also just like to add and reinforce that child development is all about systems. These pictures are part of or come from the Human Connectome project led by King's College London and show group maps of neural networks in over 300 one-week-old newborns. Children's brain development has all the features of complex systems. There's a non-linear process of self-organisation with emergence of new skills, as we know, occurring through numerous interactions and feedback with others, with the environment. And yet, as Aisha said, in spite of much progress, our progress, towards the SDG goals could be better. And our team hypothesised that potentially application of systems thinking could be one tool to improve scaling or improve progress against scaling sustainability and equity challenges in ECD policy and programs. However, in thinking about the application of systems thinking, we're very mindful that systems thinking is not new and that it includes knowledge, whole depths of knowledge across multiple disciplines over decades and arguably much longer. So we were keen to understand more about what is known and also to be evidence informed in our approach to inquiry. We didn't want to just drink the Kool-Aid of systems thinking, so to speak, but to be rigorous in our approach. So we undertook a mixed method evidence review, which asked the question, what is the impact of complex systems interventions on diverse outcomes at scale across sectors? We screened over 42,000 papers across 3 databases and included 5 papers from within this huge number. We also undertook over 30 key informant interviews with people who had a diverse experience in ECD and in systems thinking.
Sorry, Kate, to interrupt you. Are you presenting slides? Because we don't see anything.
Okay, yep, I'm presenting them and I thought we were sharing them. That's all right. That's all right, let's keep talking. So the main point of this slide is to say that the findings of our evidence review are available on the ECDAN website. And we're very delighted that of the 5 complex systems interventions that we reviewed in detail in our evidence review, the authors of 4 of those are joining us as expert panelists today. And they represent these complex systems interventions which were implemented at subnational scale in 5 countries, Nepal, Vietnam, Ghana, Uganda, and India. All were implemented within existing government health and other systems. They varied in the application of systems thinking tools and methods, and all we think provided a really rich description of lessons, challenges, and enablers in the applications of systems thinking which are relevant to ECD. And excitingly, all showed positive impact on their multifaceted systems interventions on population outcomes at scale. So without further ado, I'll hand back to Shakufe to introduce our amazing speakers.
Thanks, Kate. And what we'll do, since we didn't see the slides, we'll have all the presentations as one PDF, and we'll share them along with the recording. So Kate, if you can stop sharing. Wonderful. So it's my pleasure to introduce you to Dr. Gary Darmstadt, who is joining us at 3:30 in the morning from where he is. And so he's the Associate Dean for Maternal and Child Health and a Professor of Neonatal and Developmental Medicine in the Department of Pediatrics at the Stanford University School of Medicine. Over to you.
Okay, thank you very much. It's really great to be here and really thrilled that you chose our study for further examination. So let me get rid of my chat here. Okay. I'm going to be speaking to you about our program in Bihar. I'm going to be going through these slides very quickly to try to get through a lot of information. This was a multi-organizational partnership centered around the government, in which techno-managerial support was provided to the government in their implementation. There were multiple papers that came out of this study for your reference. We had 8 focus districts comprising about 25 million population, in which we developed innovations that then were transferred into scale up across the 38 districts throughout the state of Bihar. And this was all done through support of government implementation. We had a program theory of change that looked at supply side interventions around building capacity of frontline workers, improving quality of care in facilities, leading to improved interactions with families and improved quality of care. There were multimedia communications and self-help group actions that were aimed to lead to behavior change and to changes in social norms, all leading to improvement in maternal, newborn, child health and nutrition. We had an evaluation that was aligned to the theory of change. Here you can see, I'm trying to grab my pointer, we had a before and after implementation in the 8 focus districts that was quite intensive implementation support. We then went on to scaling up over this period of time, and there was a gap in implementation here that I'll be referring to. So in this first slide, you can see that we've laid out our indicators. We had 51 indicators laid out by the continuum of care, and also displayed according to the target for the various interventions. And there are 47 different interventions that we packaged together and described as frontline worker actions or behavior, maternal decisions, or facility outreach service delivery. In this first phase, in the focus phase, we found that 40% of indicators changed in the comparison area from before or after. So this was a secular change, and if you didn't have that control area, you would be attributing program impact to secular change. We were able to attribute change in 10% of indicators to the program, demonstrating that large-scale change over 25 million population was possible, but structural health system constraints limited behavior change. So in the next phase, care that was providing support to the government shifted their focus from building capacity of the frontline worker platform to health system strengthening and quality improvement in facilities. And this had some implications for equity, as I'll briefly mention. Now, during this gap between the focus phase and the scale-up phase, about more than two-thirds of the indicators fell back to their baseline levels. Going forward, in the 8 focus districts, those indicators did not dip below baseline. But when we looked in the trends over time in districts that had been focused and districts that were non-focused, that were now receiving the implementation in the scale-up phase, their changes over time were about the same, leading us to conclude that health systems in that focus phase had neither been strengthened nor further destabilized in the pilot phase. We also found that the average trends at the district level marked variations at block level. So we did some geospatial analysis shown here. You see in blue blocks where there were increases in these indicators. The orange is where there were decreases. The clear is where there were none. You can see it's highly variable. 15 indicators out of 22 in this analysis went in opposite directions. We also looked at contextual factors and found that night lighting and frontline worker visits were really key. But this was an indication that contextual factors are extremely important to understand and that are often holding back our implementation success. We found that mHealth and health layering of self-help groups was very effective. But when we did an equity analysis looking at the extremes of wealth and caste, we saw that changes in indicators were largely driven by changes in the least marginalized subgroup, and that disparity tended to widen for indicators that were dependent on people going to health facilities for care, and suggesting that you can see program improvements at the expense of accentuated inequality. And we found that intersectional equity analysis is really quite challenging. We went on to do system dynamics. There's a causal map, trying to gain greater precision in how to intervene and doing simulations to guide intervention approaches. And so my final reflections are that multiple innovations were developed. I've listed some of them here, but health system dysfunction limited their effectiveness. So you can create all kinds of effective interventions, but ultimately where you place them within the health system really matters. Health system performance can be improved. It can be done fairly rapidly. But the interventions, the innovations need to be integrated into evidence-based programs. You need to have sufficient governmental commitment, intensity of implementation, and resources. Reach to the most marginalized doesn't just happen. It's got to be intentional and it's got to be monitored. Also, measure change at the lowest possible implementation unit. Summary measures at a program level can mask marked variation at local levels, which holds that variability holds a lot of information, a lot of clues to how to make your implementation more effective. And system tools like system dynamics can help with simulated policy experiments that can aid your precision. So my final conclusion out of the whole study was here that success in implementation really requires maintaining a focus on the achievement of shared goals. We found that this was really important, bringing people around a shared goal, a unified theory of change across all of the partners, thinking about community and facility implementation, looking at disaggregated data according to aspects of marginalization, such as wealth, race, and gender. You got to maintain optimism throughout this, a sense of urgency, innovation, and flexibility to respond to what you're learning, and the evidence of what is being achieved, for whom, where, why, or why not. Thank you.
Thanks so much, Dr. Dormstead. All right, that was so rich. I think we can spend an hour with that, but I'm going to turn it over now to Dr. Peter Wasavik. Apologies. He's the Associate Professor at Macquarie University, the School of Public Health, the College of Health Sciences in Uganda. Over to you.
Thank you so much for inviting me. So we in Uganda wanted to ask the question, can a focus on the system improve child health? So we had this project, the District Health System Strengthening for Child Health through the code study in Uganda. That project was called Community and District Empowerment for Care. And here are some of my authors, Professor Stefan Peterson and Flavia Mpanga Kagwa from UNICEF. The project was funded by the Gates Foundation and had these collaborators, as you can see. The objective of the code study was a large cluster randomized controlled trial that investigated the effect of district management strategies on by use of local data and community dialogue to improve child health. And so I wanted to know whether when you focus on use of evidence and bring communities on board, can it improve child health? It was a large study in 8 districts as intervention and 8 control districts. And we had a national oversight committee led by the Ministry of Health and the partners. We had the hypothesis that the areas of the district that receive the code's intervention will perform better and show accelerated improvement on child health compared to the control areas. The code's project has 3 major pillars. The first pillar was use of evidence. The second pillar was regular review of district performance based on data. And the third pillar was community oversight and inputs. We undertook several steps to do codes. We did on the supply side, where we collect data through lot quality assurance, but also through the DHIS tool. I must say later, because lot quality assurance was expensive, we were able to get to use regular data from the system. And then on the community side, we also collected data for social accountability through a system that UNICEF developed called U-Report, where they do surveys among some committee members who report, and then do regular community dialogue at the village level. And then based on this data, which would analyze at district level by the district themselves, they would analyze the district performance and identify gaps. And based on the gaps, they would come up with strategies for strengthening the health system. For codes, we adopted a model for systems improvement called the Tanahashi model. And Tanahashi looks at several areas of a system performance. Particularly here, we're looking at availability of commodities like medicines for child health in districts, availability of human resources, as you can see in the bars, then access to physical services, how accessible are the services to community members, and then how soon do they utilize, do they come to utilize the health services? And do they continue to utilize the health services once they initiate, like utilization of health services for malaria treatment? And eventually at the end, as you can see at the end of this slide, is what we call the quality coverage. If you have gotten all these, a child who gets all these is considered to get quality coverage. But you can see that based on this yellow thing that, there is a gap eventually, especially on the quality coverage. And that is what we eventually wanted to strengthen. So as step number 1 was that use of data and analysis. Step number 2 now, based on the data and understand the gaps, we'll do what we call a causal analysis. What is causing these gaps? And we'll do so by asking 5 important questions, mainly why? And these are things that a district manager should be able to intervene in, like decision space, use of resources, capacity, motivation, etc. And having understood what is causing these problems, then we go to the next step. We identify the solutions. The district leaders identify management and leadership related solutions and the strategies for improving the performance of health systems in the district. So they would put these strategies in their work plans and then implement. And so based on the implementation of the course project, as I said, starting with the use of data from both facility and community, and then analyzing and asking why, then these are the improvements we saw. We saw improvement in child health indicators. We also saw improvement in reporting in DHIS2. We saw a decrease in health worker absenteeism. We also saw that most districts had improved work plans and also budget. Eventually, codes was scaled up in Uganda because we engaged with the ministry, and now they use it as the main strategy for district planning. And these are the key lessons learned, that we need to align with existing national planning approaches. Bottleneck and cause analysis is useful, and use of continuous quality improvement can help bridge gaps. Bringing the community on board is so critical, but it's not usually easy. You need to align it to existing community structures. And the political and technical leadership is so important. I think the importance of leadership, both political and technical, is so critical for systems to work. And there is limited utility unless there is increased fiscal space. So there must be some budgeting that is flexible. Thank you so much.
Perfect. Thank you so much, Dr. Wesawa. That was exactly 5 minutes. And if you can take your slides down, encourage everyone as you're listening to put in your questions for the panelists in the Q&A so you don't forget. In the chat is where we share resources, and you can share your own experiences and reflections. But now, without further ado, it's my pleasure to introduce you to Dr. Phang Nguyen, the Senior Research Fellow in the Poverty, Health, and Nutrition Division of the International Food Policy Research Institute in Vietnam. Over to you, Phang. Phang, are you able to unmute yourself? We don't hear you.
Can you hear me now?
Yes, we can.
Yeah, thank you for the introduction. So let me try.
So while Dr. Phang is getting ready, again, I encourage you to put your Q&A in the Q&A box and share your reflections from the two presentations you've heard before. We're very keen on, especially in how we can learn from these different sectors for early childhood development. Okay, are you ready?
For some reason my screen looked a bit. Is that okay to see on the screen?
Sure. Would you mind pressing the display settings and clicking on?
Because it have two things next to each other, right? I am able to share that before, but now it's a little bit different.
Okay,
so
no problem. Why don't you begin, and maybe Jackie can share your presentation because she has the slides. So why don't you begin?
Okay, thank you. Yeah. So
maybe you can take your slides down and Jackie can share and you can begin.
Okay, if she can have to share, that's great. Yeah.
Well, would you like to begin, Dr. Phang? Just begin your presentation.
Yeah.
Actually.
Yeah. So I would like to share the insight from multiple evaluation behavioral change intervention to improve infant and young child feeding practices in Vietnam. And I also want to talk a little bit in Bangladesh because that's the two countries are in parallel. So are you able to share my screen? Hello?
Jackie, are you able to share? There we go.
Okay, great. Yes. So nutrition and development closely linked through both biology and behavior. and promotion of adequate nutrition in early life through interventions that aim at improving infant and young child feeding practice has potential to contribute to cognitive, motor, social, emotion development, but very limited evidence exists on what impact can be achieved. So given that in the multiple evaluation from Alliance Thrive efforts, we examine the impact of system strengthening intervention on impact on breastfeeding, complementary feeding practices, and child development in Bangladesh and in Vietnam. Next, please. So in Bangladesh, we mainly use the outreach through NGO platform. That means we engage the frontline worker at different level for delivering the counseling of nutrition services through the NGO platform. And this platform is the last NGO in Bangladesh. We also use a social mobilization that mobilize all the religious leader, community leader, and the women in the community to support each other for the counseling services. In terms of mass media, we use a TV-based mass media program and develop a lot of like local context message to deliver to the mother and the children. Next, please. So in Vietnam, we use very innovative methods that's the social franchise model. So basically, we use the existing community health system in Vietnam. The community health center is already there to provide the preventive medicine, but more mainly the curative one, but very little intention to be focused on preventive medicine. So we upgrade the facility to make it more visual attractive, and then also train the health worker for the knowledge and skill of counseling on infant and young child feeding practices that they can provide the service to people. And in terms of mass media, we do both in the mass media with the TV base and then also in the web base, because the web base is pretty developed in Vietnam. Next, please. So we did several evaluations. The first one is the impact evaluation that we found that both the program in Bangladesh and Vietnam have a large effect on exclusive breastfeeding. Just example, we can show here the green line is for Bangladesh. The dotted one is the control group, and then the solid one is for intervention group. So we can see in both countries, it shows last impact about 30 to 40 percentage point improvement in exclusive breastfeeding in both countries. Next, please. And then in complementary feeding, we can see also very large difference in both two countries. Just example in Bangladesh, sorry. Can you show back to the screen again? Or I can share in my screen.
Shakir, are you able to share?
Oh, okay. Can you go to that slide, please? The next one, please. Yeah. So in terms of complementary feeding in Bangladesh, we can see that it's very low at the beginning, about 30 percentage point. About 30% of the children achieve minimum dietary diversity. But at the end of the project, the intervention group is more than double to 60%. The control group also increased a little, but the impact here is so much more in the intervention group. In Vietnam, we see very different story that at the baseline, it's already pretty high, about 74–75% of children achieve the dietary diversity. Therefore, at the end, we also see slightly improvement that prefer on the intervention, about 5 percentage point only. Next, please. Then we also assess the impact of the intervention in both language and motor development of children in Bangladesh, because that's a place that shows the last impact. So we can see here on the left that the intervention program have impact on minimum dietary diversity, meal frequency, and consumption of iron-rich food, which in turn the diversity have an impact on language development. And the indirect effect here is about 9% of the total effect. In terms of the motor development, we also see the impact of program on the motor development, and the indirect effect here is about 30% of the total effect. Next, please. Beyond the impact evaluation,
Sorry, Feng. Jackie, are you
Yeah.
able to make it full screen because we can't see it? And Dr. Feng, you have about a minute left. So if you can focus on the systems aspects of it, that would be great.
Yeah. So we also so beyond the impact, we also conduct the we also conduct several study to open the box to try to see the impact, how it impact on the system one. Just example here on the left, we can see that incorporating element of social franchise in the government health system have improved the skill of the health workers, the quality of counseling service. But several challenges still lie in the demand side. That means that we need to create the demand side for people to use the health services. Next, please. Next slide, please. So we also conducted the policy analysis to see how it worked on the system strengthening, and we see that the really important of the policy in support. Just example, the policy here have a shift in policy discourse to put more priority in nutrition, in infant and young child feeding, and in early childhood development. There's a lot of actors that engage in that, but there's some conflict on that. Just example that several groups that encourage the activity, but some other groups, just like formula industry or the business, it may have some conflict of interest because they may want to pose the formulas that can have a negative impact on the optimal infant and young child feeding. The target policy and advocacy also have the stakeholder alignment and implementation capacity. And there's still a lot of challenge in terms of policy implementation, challenge in commitment to funding on implementation and enforcement on the system strengthening or changing. Next, please. So the last takeaway message is intervention delivered at large scale was able to shift feeding practice and key development milestones. But the experience here is we really need to embed it in the current health system, use a supportive system, and to provide further investment and exploration for integration in the focus on infant and the large-scale nutrition program. Thank you.
Thank you so much, Dr. Feng.
Yeah,
And
sorry.
finally, no problem. I'm going to move on to Dr. Rafael Perez Escamilla, who wasn't one of the 5 authors whose papers came up in the systematic review, but who has done incredible work. And so he's a professor at the Yale School of Public Health, the director of the Office of Public Health Practice, the Global Health Concentration, and the Maternal Child Health Promotion Program. So over to you, Rafael. Go ahead.
Thank you very much for giving me the opportunity to present today. I am assuming you can see my presentation in full.
Mm-hmm.
Okay,
yeah.
so
Not now. We were able to see it in full, and now we don't see it in full anymore.
Okay, so we should be okay
yes.
now, correct? Yes.
Correct.
So what I'm going to do is to talk to you about the experience of my team scaling up breastfeeding programs through the systems thinking lens. So my team at Yale over 10 years ago started asking the question as to how come exclusive breastfeeding rates continue to be so low globally as we speak, in the context that we really understand what it takes to make breastfeeding work on a large scale. So based on this important question, we embarked on a very in-depth systems analysis based on the complex adaptive healthcare systems framework to actually understand what had the countries that had been very successful at scaling up their breastfeeding programs had actually done. And to make a very long story short, we ended up expressing the findings from our analysis through the breastfeeding gear. And the breastfeeding gear model essentially envisions the national breastfeeding programs as complex motors or engines that require to have very strong gears in place that are interlocked with each other. So the first gear is evidence-based advocacy that is essential for leading to the creation of the political will that is absolutely required to pass a crucial legislation for breastfeeding protection, as well as policies to release the financial and other types of resources that are needed to be able to properly train the workforce to implement the effect evidence-based programs that we know work very well at both the facility and the community level to promote and protect breastfeeding. We also know that these countries have invested also a bit of thinking and some financial resources on very clever social and behavior change communication campaigns. And we also know that those countries invested in conducting operations, operational research and evaluation, what we would now refer to as implementation practices or implementation operations. And at the end of the day, all the countries that were successful at the time with their scale-up of breastfeeding programs had actually a master gear, which was really a very well-empowered national coordination entity that was responsible for helping set goals and monitoring how well or not the gears were functioning, interlocking with each other, and also invested in order to do this on management information systems that oftentimes had to be decentralized from the national to the local level. So this is in essence the breastfeeding gear model. And the next step was to develop evidence-based indicators or benchmarks for each of these gears so that the countries themselves could establish a process that is called becoming breastfeeding friendly to actually assess the strength or weaknesses of each gear, and through an intersectoral committee that includes government representation, civil society representation, international agencies, and academicians to develop together policy recommendations that are achievable and are evidence-based and can really make a difference in moving forward the quality and coverage of breastfeeding protection, promotion, and support services across sectors. And here you have the papers when you can read more about it. BBF has been successfully tested over the past 7 years for feasibility and policy impact across 8 countries located in 5 world regions. And there are more and more countries that are doing this now on their own. Mexico, for example, has done it 3 times already and is preparing for the 4th wave of running the BBF process. And in all instances, we have very clear examples of how policy advances have been made as a result of running the BBF process based on the breastfeeding gear model. In fact, Germany has based its new breastfeeding national strategy and program totally based on the BBF process that they ran so effectively, with very specific budget allocations for the implementation of their policies. And if you read this paper, there are many more examples that you can benefit from. And in all instances where we have studied this, and we're publishing a paper from Samoa that is in press, in fact, the process shows that data was very, very important in informing the scores, and at the end of the day, the recommendations that were made to the policy makers. So in conclusions, systems thinking is needed to design effective policy toolboxes to support multi-sectoral evidence-based decision-making in the area of breastfeeding. Thank you very much.
Thank you so much, Rafael. All right, and now for the last speaker whose paper was part of the evidence review, Dr. Ashish KC, who's a senior lecturer at the Global Health School of Public Health and Community Medicine at the University of Gothenburg, and is the associate professor of Women's and Children's Health at Uppsala University. You must have more time than the rest of us, Dr. Ashish, but over to you in 5 minutes. Just a quick note, we're going to go into discussion after this. If you can put your questions in the Q&A, some have been answered, and also to the panelists to respond to some questions directed to you in the Q&A. Over to you, Dr. Ashish.
Yeah, thank you. So what I'll be presenting would be the scale up of the newborn resuscitation program within the health system setting in the hospitals of Nepal. As we all know that there are several health system challenges to implement any protocol or guideline in clinical care settings. Despite the guideline being developed through a rigorous process, the implementation gap, especially in health system setting, leads to a poor delivery of protocol. As a result, every year almost 1 million newborn die due to poor quality of care. The health system's barrier, as shown in the figures, are common, but most of them is linked with the leadership and governance, health workforce, and availability of technology. And optimizing these elements together can save lives. And these complex barriers and system barriers are the ones that we aim to tackle to the scale up of a quality interventions in Nepal. So how did we do it? What we did was we strengthened the hospital leadership using the existing governance structure. So we strengthened the current structure within the hospitals for perinatal care. We also worked with the interdisciplinary team to introduce new interventions on resuscitation. And then we identified the key facilitators within the hospitals who would then introduce QI interventions in the hospitals, which would be daily drills, self-assessment checklist, a plan to study cycle on a periodic basis, and then measuring this care over the period of time. What we found and where we did it in 12 hospitals. The implementation was done in a stepwise manner, which means that it also mimicked a cluster randomized trial where each wages. So we had 12 hospitals. Of the 12 hospitals, we selected 3 hospitals, a high volume, a medium volume, and a low volume hospital as a one wage. And each of them were implemented, each wage was implemented within a span of 3 months gap with the other wage hospitals. And these hospitals were high volume hospitals, medium volume and low volume, and had high mortality settings. What we found, within the 12 months of implementation of interventions, of the QI interventions in these hospitals, the interpartum related mortality, that is the interpartum stillbirth and the first day mortality, reduced from 10.7 per thousand birth to 7.8 per thousand birth, indicating 21% reduction in the mortality. So what did we learn? What we then came to an understanding with this reduction in the mortality over the period of 18 months was that implementation of any intervention, especially a clinical protocol, is a complex phenomena and requires systems thinking. That means that there's a black box in place, and to overcome this black box, we need to have the understanding of the context. And context is valuable because that provides the understanding what are the key barriers within hospitals or a setting or a facility, and then try to solve them, not through an external person, but through and within the systems. And using the leaders as a key levers of opportunity to improve the systems, and then improving governance of these leaders at different levels. So not only at the hospital directors level, but also at the lowest clinical level. And then engaging interdisciplinary teams, doctors, nurses, support staff as a team to improve the governance and to implement change. And engaging them as a local facilitators is the other key factors. The most important of all is using these QI tools and approaches such as drills, self-assessment checklist, and the quality improvement meetings to further improve, measure, and improve. And so there's a continuous process of improvement. The similar approach has now been taken up in Tanzania, which has now been scaled up in 40 different hospitals, and also now in Sweden in several hospitals in Sweden. And thank you. And we had a team within the Uppsala University and also from Nepal doing this study. Thank you very much. Over to you, Sita.
Thank you so much, Dr. Ashish. Ashish, keep your video on, and if you can take your screen down. And now it's my pleasure to introduce you to Dr. Sharon Goldfeld from the Murdoch Children's Research Institute, who will be moderating the Q&A for us today. So over to you, Sharon, and if I can encourage all the panel or all the speakers from the presentations, Ashish, Gary, Peter, and Raphael and Fong to start their videos. Over to you, Sharon.
I too am acknowledging the traditional owners of the land that I'm on, which is the Bunurong people of the Kulin Nation, and pay my respect to elders past, present. Panel. We're going to have to see you, I'm afraid, panelists. So Raphael, Fong, Gary, could you all...
Sharon, they're already on video.
Okay, so can you hear me or am I frozen?
Yeah, you keep going in and out.
Just, don't you love life? Okay,
right,
well, I left the
Sharon.
building, but I'm back. I also just want to acknowledge all of the audience here today. I know that you're from a number of different countries all over the world, different time zones. I think Gary still wins the prize for joining us at such an extraordinary hour. And then finally, just wanted to acknowledge the different papers that we're seeing and the different bits of research. And I think what's really fascinating for us in trying to look at where we've seen outcomes that we can measure for systems change and systems thinking is that they do still sit in child health mainly, and that they do sit in low and middle income countries. And I wonder if that goes to the innovation that sits within low middle income countries that we don't see in high income countries. So, and it's a real testament to all of you as well. But because I don't want to, I'm aware of the time, what I'd like to do is I'm going to go around to each of you as panelists and ask you if, like, the first question is a kind of rapid fire question. So I'll get your initial kind of thoughts, and then I've got a more detailed question for each of you, and then we'll go to the audience and get some of their questions as well. So I'm just going to go around the Zoom for me. And Peter, I might start with you, and I'm going to ask you each this same question. So I know you've seen it before, but in your experience, what do you think were the real barriers and enablers to systems thinking for what your work did in your experience? What do you think might be the kind of relevance to early childhood development? And my little one at the end, which is there a secret sauce here that we kind of can draw on? So over to you, Peter.
Thank you so much. No secret sauce. Maybe we could start from there. So I'll start with the enablers, just to be nice, that if people know, sometimes you, like I think Amanda put in the comment section, sometimes confusing health system strengthening with system thinking. Although you can, in fact, there's a book, System Thinking for Health System Strengthening by Don DeSavage and WHO. So system thinking can help health system strengthening. In fact, that is how it should be. So one is actually having a knowledge and of it, that you know what a system is and what system thinking is. And then to believe in it, because we struggle with when people don't believe in systems and they like these fragmented things, which fail to work together. Financing is quite important. And as you can know, especially for research, that there are very few people who actually fund a complex study. And many of them want simple things like analysis through like the ones we do for drugs. And how can you apply this to? So that is a major problem. Then skills and having champions, but also some barriers and a lack of leadership. In fact, leadership is both an enabler and also a lack of it is actually a major thing. As you saw in my presentation, we were focusing on the role of leadership and management in managing the system and to improve child health. I've talked about the lack of financing, and then this whole problem of what I call projectization, whereby everything is a project. You can't be having projects and a short period of implementation, and you're able to do a good system thinking. Let me stop here for maybe finally, how to measure is actually one of the challenges with system thinking. Thank you.
Thank you, Peter. And there's such important points. I'm going to go to you, Fong, because I know that you might have to leave us a bit early, and I want you to make sure that you've got this opportunity to respond to the same questions about barriers, enablers, and any kind of catalytic things that you thought were really important for your work.
Okay, thank you. So in the work that we are doing, there's few questions in the chat also. So I just want to explain a little bit more that the concept of social franchise, that means we want to have the counseling rooms that is standardized across, that have both the quality of the room, quality of the staff, and then quality of the message that the people provide for the people. So in order to do that, first we need to, the concept of social franchise is very new, because it mainly apply in the business more than in the health, except. So that's why first the challenge is how to get the government buy-in and to support it to do it. And then we need to work through that to several partners, and then the health community worker and all kind of people to get them excited about the idea. And after that, we need to have the demand, because when the room is already there, the people already there, the staff already trained, but people don't have the habit of going for counseling. They only bring the children to the health center when they are sick or they are ill. So that's why we also really need to have a demand creation for the service. And then in order to do the demand creation, the one quick way is through the TV, but always the TV advertisement is very expensive. So we need to have a more other way, just example that we do in the website. We also have the banner in the bus. We have a banner on the community center. So I mean, both the supply side here and the demand side are really important for the system strengthening that really absorbed by the people. Yes, that's our main experience. Yeah.
Thanks very much, Fong. And you're seeing, your other speakers are seeing some of these issues around system strengthening versus systems thinking, the use of these different newer technologies that are needed, and also some of the issues I thought that Peter brought up around the donors and what people actually fund or be prepared to fund. Gary, I might go to you next. What do you think are some of the barriers and enablers, and anything you think is really catalytic, and recommendations for us in the ECD sector?
Yeah, thank you. I think the biggest barrier is linear reductionist thinking. You know, the idea that we can break things down into small pieces that are related in a linear fashion and failing to recognize the interrelationship among factors, failing to recognize the importance of the context. I think that this is really a key. We live in a world where vertical programming tends to be funded, where evaluations tend to be underfunded, and where a learning environment often is not set up from the beginning and funded appropriately, so that you're gaining information, you're digesting that information in rapid fashion, you're discussing, feeding back, learning, and adapting. We often think that we need to implement something and then measure something, and I think that some of this thinking is perhaps the major barrier to using systems thinking in our programs. Particularly when you get to scale and when you're working with multiple partners, it becomes extremely important to be aligned on your goal, to be aligned on your theory of change, to be aligned on your measurement framework, and to have a forum for discussion, where all parties can come together and share what they are observing, what they're learning, have governance around decision-making, have a clear pathway around how you're going to use data for change, and then measure that change. Even data sharing among partners within a project can really be quite challenging, and it needs to be all worked out ahead of time. And again, the alignment on the theory of change, I think, is extremely important. And this aspect of multi-sectoral collaboration for the ECD community is very, very important, very hard to do. We tend to not communicate. We also tend to wall off evaluators from implementers. So often the evaluators may not really understand what it was that the implementers were aiming to achieve and how they went about achieving that. One other final thing I'll mention is just process evaluation along the way, to understand what's being delivered, who's receiving it, and what kind of impact it's having, what kind of spillover there may be, which is also important for sustainability. So I'll stop there.
Thanks so much, Gary. And there's quite a few things in the chat going on. I think you're having a lot of reinforcement of what you're saying through the chat. Ashish, over to you. What are the kind of barriers, enablers, and kind of catalytic things you think are important for us in ECD?
Yeah, picking back from what Gary mentioned is this contextual understanding. And I think one of the key for implementing in a complex environment, especially in low resource setting, is understanding the governance model. So especially in low resource setting, besides the leader being assigned or that those are being the officer leaders, there are informal leaders and champions, and identifying those champions who are being looked upon by as leaders by others in the community, or in, let's say, in hospitals by other nurses and doctors as a champion in a certain care or provision of care, is a key and the driver. So if we don't understand the context of the governance models or the key champion models, then I think that might be a losing ticket. And I think identifying those champions and using them as a vehicle to introduce or at least facilitate new intervention is a key for successful implementation of an intervention.
Thanks, Ashish. And I think it's so interesting that you're actually picking up different things. So we've heard a lot about data, governance, partnerships, all the things that I think we know are part of systems thinking. But your experience out in the field, I think, is really helpful in saying, well, these things can be done, but you've got to think about them. Raphael, you've had this global view over a lot of these ECD evaluations. What do you think are some of the barriers and enablers for ECD in particular?
I think the lack of a culture of intersectoral collaboration through systems coordination, in my view, is the biggest challenge that we have to deal with in the 21st century. And we need to understand why that is. And it is, I think, because systems thinking is not that simple and it's not as intuitive as some have had previously believed it should be. So essentially, when we look at the different levels of workforce, from presidents, ministers, all the way to frontline workers, they have hardly any kind of systems thinking in their training and their background. So we really need to train a new workforce that really uses systems thinking approaches for problem solving. But at the end of the day, there needs to be the political will, the incentives for the sectors to collaborate, and even the subsectors to collaborate with each other. Because nowadays, that's not there are very little incentives. In fact, the biggest incentives are perhaps to hog the ball and try to claim that your program in your sector or your contribution from your sector is the most important, and that from any other sector. So what we have done through the BBF process, and I think the ECD area could benefit from a gear model and a BBF-like process as well, is to actually bring together, oftentimes for the first time, the different sectors, subsectors, civil society, international organizations, and academicians, for them to see they don't need to fear each other when there is a political will to have a national initiative, a national result, a national program, and that no one is going to be taken resources away or making their lives more difficult, but rather by collaborating, using the systems thinking approach, they will end up, all of them, contributing collectively to huge outcomes, such as improved early childhood development, that are so important for the future of the country. So I would say that we have very few processes like BBF in place in the area of early childhood development that are really designed to empower countries through processes that involve evidence-based policy toolboxes that are run by the countries with a transparent governance. Everybody has an equal say, and everybody can actually think openly and without fear of anything for the common good. So that would be my response in terms of how we have tried to overcome this immense barrier when it comes to the BBF process.
And maybe I can just follow up with you, Raphael, with just, can I dig in a little bit deeper, both from your BBF experience, but also in sort of the case reviews that you've done of some of the other ECD initiatives. And I wonder if you can, we can talk a little bit about how national and sub-national leadership, where it's been kind of effective or successful, and what can we learn from that? Because I think we're now going to start to drill in a little bit about some of.
Mm-hmm. So
can you reflect a little bit on that?
Yeah, I didn't finish listening your question, but I think I got the thrust of it. So I do, in my experience, I have now interviewed for my own research lots of decision makers in the field of maternal, infant, and young child feeding in different nurturing care sectors. And what is very wonderful is that the vast majority of leaders are very sensitized to how important it is, and they want to see results. That is something that the Lancet series from 2016 on nurturing care, the 2016 Lancet series on breastfeeding, for example, had a major impact. So I feel that many of the decision makers, they honestly want to see results. They want to see this working. But if that is not in place, that political will is not in place, we know that nothing is going to happen. And the second reality that they face is that it's very easy for us to say, oh, we will redesign the systems. Good luck with that. We have to work with the systems that are available in the countries and use implementation science to optimize the integration of early childhood development across the board based on those systems. In some countries, really the strongest sector is education. In others, the strongest sector is health. In others, the strongest sector is social development when it comes to the resources that they happen to have. But that does not mean they cannot coordinate, they cannot integrate resources. but we need to work with the cards that each country has on the table to make these systems approach work. So again, going back to Gary's point about context, if we don't take context into account, if this is not co-designed by the key actors in the countries, it is not going to be sustainable, and it is not going to be appropriate for the systems that they have.
And I guess the further tension, and we might follow that up with one of the other speakers, is also at that sub-national level where you're actually having to, it's not just what happens at the policy level that gets actually translated at the local, regional level is also kind of really vital. And maybe that, Gary, is a good throw to you, because obviously with the Ananya program, it was a huge amount of scale actually. And we just wondered, you know, you obviously were scaling and you would have had to have engagement at both the local and the regional level to be able to scale with that, and also have co-design and also stacking. I think what's really interesting with your program, you actually bundled, you actually physically were stacking a whole lot of different interventions. So what do you think we can learn from, you know, basically we could keep stacking for ECD. What are your thoughts about how we might think about that from your experience?
And Sharon,
Gary, you're on mute.
I'm also noting the time and that we have 15 minutes left. So if we, yeah.
We've only got 4 speakers now, so we're good.
Okay.
We have a few audience questions too. Go ahead, Gary.
Extremely important that the understanding around goals, what you're trying to achieve and how you're going about it, goes from the top to the very, you know, down to the ground to where implementation is occurring. And within Ananya, there were multiple structures that were set up to try to drive that. One of the effective approaches at the highest level was where the chief minister brought together the district magistrates each month and displayed certain indicators and how they were progressing. And, you know, those that were performing, you know, the districts where things were happening in an exemplary fashion were you know, received that benefit of recognition from the chief minister, and it was pretty clear who wasn't performing as well. And that, you know, became a really strong driver for people to show up and have something to present. So that was an important thing. CARE also organized, it was really important then, another example down at the ground level was bringing the frontline workers together, the ASHAs who are more about health, the Anganwadi workers who are a bit more about nutrition and child development in India, and then also the A&Ms, and brought them together at the sub-center level, which is the smallest health facility level, really more at a village level. And coordinated their activities, designed M-Health tools specifically for their use to enable their planning, their tracking of reach, and developed incentives, worked on developing team-based goals and incentives that got them working together and coordinating who provides what, who's reaching whom, who is everyone that you need to reach, you know, mapping that out. So there were a number of activities like that you know, spanned the various highest political level down to the ground that were really aimed at trying to coordinate people's efforts and motivate them towards achievement of a common goal. And really the conversation ultimately was what was key at really all of those levels.
And I think, you know, a lesson that you can actually measure impact even with that level of complexity. Shakif, I think we've got some questions from the audience. So Ashish and Peter, rather than hearing boring me, we might hear from one of the audiences and we'll throw one of those questions to you. So Shakif, who have we got?
Yeah, Donna Harris, do you want to unmute yourself, introduce yourself, and maybe ask some of the questions you have in the Q&A, which I think are quite pertinent to this conversation. Go ahead, Donna.
Yeah, sure. Thank you, the panel. This is really interesting. And I've actually been thinking about incorporating systems.
Sorry, Donna, can you introduce yourself?
Oh, sorry. Yes, Donna Harris, Monitoring, Evaluation and Learning Director at EDI Global. Also a lecturer and researcher, University of Oxford in the UK. Yeah, sorry, as I was saying, I've been thinking about incorporating systems into MEL. And I think the question I had was, can you share experience? So there are two questions. The first one was about being participatory and involving stakeholders, which you guys were talking about earlier. Can we actually use the process of system mapping or stakeholder mapping to engage with key stakeholders? And if you have done that, can you share your experience? How challenging was it to bring people together to do this mapping? So that was the first question. And the second question is about a challenge around incorporating systems into theory of change, and how do we measure progress and changes within the system, and also take into account feedback loops. So these are my two questions. Thank you.
Thanks, Donna, and really relevant. So I might go to you first, Ashish, if that's okay, and get you to answer. The questions were around the stakeholder involvement and systems mapping, and the second one obviously around monitoring. Did you want to? You can answer both or one, whichever you prefer.
I can take one. So the first one. So as a part of the context assessment, one key thing is to understand and map the stakeholders within the system. And those stakeholders might be at different levels, might be at macro level, meso level, or a macro level. So mapping those stakeholders and identifying within those stakeholders who are the champions are key. And we use those tools on the context assessment, which is a fairly simple tool to identify the stakeholders and engaging them to identify and prioritize what interventions are required to improve the change or bring the change. Because as I said, newborn resuscitation is nothing very new, but identifying within those stakeholders what are the key barriers to implement those interventions is the key. And I think identifying those stakeholders at the different levels would be key, and engaging them. So yeah, as you rightly mentioned, that stakeholder mapping is a key process, but that comes into umbrella of the context assessment and context improvement.
Thanks, Ashish. And we were just saying that it sounds like people have got some great tools. So if anyone, including our panelists, wants to put any of those tools into the chat, I think it'd be great, because we'll be able to follow that up and distribute those to the rest of the audience. And Peter, would you like to maybe tackle the second question, which was really about the use of monitoring feedback loops? It's actually quite a lot of what many of the other speakers have spoken about. Peter, are you able to answer that one?
Thank you so much. So yeah, monitoring is always critical, but a bit complex with system thinking, because it does not necessarily apply itself to the normal quantity methods that we want to use. Many times we want to know how the system is working. But of course, if the system is performing, it should be able to produce some outputs that you can measure quantitatively. In our case, some of the major outputs we focused on were measures of child health, including immunization rates, attendance of clinics, and stuff like that. But along the way, we also did qualitative analysis, and also had so many meetings with stakeholders to try to engage, to understand what is working and what is not working. I must say, this is an area where we need to be developing more tools. And some people have used a theory-based approach to actually monitoring and evaluating system performance. Even when you do so, many times you find that you need to open up and come up with even newer theories. So it's an area that is continuously evolving, and we need to develop better tools for monitoring and evaluation. I must say, as I said, one of the major ones are mainly qualitative. So we people who are into quantitative methods, I think we need to learn how to use both, and especially in understanding system interaction. Thank you.
Yeah, I think you're so right. And, we talked about implementation science. There's also obviously improvement science and its applicability into these systems. And so it's how do we use these data to both provide feedback loops, but also, I guess, hear from people's voices and know what did you do differently and how do you share that. So we talked about that a little bit, but these kind of communities of practice, I think someone else spoke about that as well, because that's about the scaling issue. Shagufe, do we have some other questions?
I want to give the last word to Maniza. She put a great comment in there, especially as it comes to early childhood. So Maniza, I'll turn it over to you, but I also want to encourage all the panelists, Raphael, Gary, if you haven't responded, please share in the chat this question about tools. We actually have a lot of questions on measurements and tools in the Q&A. So if you're able to share, that would be great. Over to you, Maniza.
Oh, wow. Put on the spot a bit. Good afternoon. My name is Maniza Intekum, and I'm a senior program officer working at the Hilton Foundation. We've been supporting work, just really trying to think about what it means to apply systems thinking to early childhood development, not based on a particular project or approach or intervention, but thinking about the system that needs to be put in place at scale, and really picking on some of these points that Gary, Raphael really spoke to around the multi-sectoral coordination. So which are even the systems and the sectors that we expect to have some kind of role in supporting young children and families, and what does that look like? What is the policy framework for that? What is the governance system and structure within that? What are the financing mechanisms within that? And kind of what are, what's our vision of a system for early childhood, or multiple systems for early childhood that function well? So I've been really interested in the discussion today, because a lot has been based on, a particular intervention and approach, mostly within the health sector, and then how you've applied systems thinking and systems strengthening to scale that more broadly. But I suppose from the other side, I'm just thinking, regardless of an intervention or a project or an approach, what actually is the ways in which we need to apply a systems thinking lens to early childhood to get all those systems working in a way that is most beneficial. So it was more, I was just putting thoughts in the chat, and then I could see we're all kind of bouncing off each other on that, but just kind of stating how we're trying to think about this and how that might be helpful for some of the work that all of us are doing. And just finally to say, and I see Audrey has mentioned is in the chat here that, we've been working with Mathematica over the last 18 months or so to think about applying a systems lens in some of the countries that we support, and really thinking about how we would measure and know whether we've made any progress or been successful in this area. So just wanted to say, great presentations, great discussions today, real food for thought, definitely for us as well. So thank you.
Did any of the panelists want to respond to that? Because it's a really interesting challenge, isn't it? Like, how do you conceptualize ECD systems, and where are the entry points where you might sort of come in for that? Is it down here at the the micro level? Is it the macro level? Do you do both at once? Do any of you, Gary, you're nodding, do you have some thoughts about it from your experience? And then I might throw to you, Raphael, as well, because I know that you have that kind of helicopter view with what you've been doing.
Yeah, I was just going to briefly say that systems exist at multiple levels. For the frontline workers, their system is their village, for example, and then the interactions that they have with the people that are supervising them. One of the things that we found to be very effective was actually mapping the areas in which those workers are working to identify the households, to identify the pregnant women, for example, and use that as a way to ensure equitable reach. Because often there was a tendency for frontline workers to visit those whom they know or with whom they share certain characteristics, and to lead to the marginalization of some who are the ones who most need the program that you're bringing. So that was an effective tool down at the micro level. One of the tools that we found to be very effective in stimulating dialogue at the policy level was system dynamics. Where you literally map the factors and their interactions and the nonlinearities in the systems, in the system, across sectors, and it really forces you to examine the assumptions that you're making, and ultimately then the evidence to support those assumptions, whether those assumptions hold or not, and ways to identify feedback loops that can be reinforcing and help drive impact, and negative reinforcing loops that can derail you. So found that to be a really useful tool.
And Raphael, you're going to get the final word here, because we're going to have to wrap up very soon. And I guess I'd really love your views on this kind of issue about with ECD, where can you and can't you come in, and where's the best place to come in? And I think what's really fascinating from all of the authors that we've heard from is that they've kind of used a hook of quite complex interventions to actually look at a systems thinking approach. So there's been a hook in there, but actually it's triggered off all these other sorts of things. And I wonder what your thoughts are on how important it is or isn't to have that sort of hook. And I think that's what Manisa was talking about as well. Like where do you enter this system to actually get some traction?
Yeah, and I think that's where it is crucial for the countries themselves to define that, because these systems are so humongous and so complex that they need to be broken down into subsystems. So the stakeholders need to agree on what it is that we are trying to do, what it is that we are trying to scale up, which are the approaches that we want to use, which are the sectors that need to be involved. How much is this going to cost? How long is it going to take? Do we have the workforce in place? There isn't a single recipe that we can give. We can present shared tools that they can use to do landscape analysis, to understand the system's interactions or lack of interactions vertically, horizontally, bottom up as well. And that's why I want to emphasize the need to empower countries with evidence-based policy toolboxes that include network analysis for identification of stakeholders, influence on each other, and so on. At the end of the day, I would say when it comes to the secret sauce for the success of large-scale implementation of these complex programs is to identify negative feedback loops as they happen and be prepared to address them via positive feedback loops to overcome them. The concept of learn as you go, our job is no longer to keep on doing autopsies of why nothing worked, but rather to make things work. That's what we should be. We should be very proactive. We need to have a monitoring and evaluation plan since the beginning. We should not launch into the massive implementation phase if the systems are not ready to do it. It's going to be a total waste of money. We have very powerful implementation science tools for countries themselves to figure out if they are ready or not to launch the projects that they are trying to launch, and that they themselves have to define what they're going to do based on their own national priorities and, quite frankly, resources in terms of financial, in terms of workforce, and so on. So I know it doesn't answer the question with a simple yes or no, but it is an issue of conveying that we have very powerful tools for empowering the countries to do this by themselves and figure this out.
Thanks so much, Raphael. And I'm going to throw to Elizabeth now to close, but and we'll pull all of these out, but such interesting learnings from all of you and such convergence around some of the issues, particularly around the use of feedback loops and microdata and giving people the ability to course correct, but not throw out the outcomes baby with the course correct bathwater. So we're still keeping an eye on what the methodologies will say. Hey, this isn't just, we're not just making this stuff up. We are actually getting better outcomes for kids. So Elizabeth, on that note, I'll throw to you to close us out.
So I'm just going to introduce her. So for the closing, Elizabeth Lule, the Executive Director of the ECD Action Network, will close us out. And then we'll have an informal chat with the panelists after that. Over to you, Elizabeth.
Thank you, Shikufe. Thank you, Sharon. What a wonderful and amazing, inspiring discussion we've had this morning. First, I'd like to thank the presenters for sharing their insights and also how systems thinking can be applied to many different issues. But also, I think your advice and guidance and what you have learned on how we can actually address the complexities of early childhood development, where we have multiple complex systems in themselves, and under those systems, there are also subsystems, and understanding the context and the complexities. And given the disruptions of and breakdown of systems with COVID-19, I think we have a unique moment and opportunity to see how we can rebuild more resilient systems that can accelerate progress so that we can regain the lost ground from COVID-19 and many other things that are happening today. I think key takeaways for me from the presenters and the comments in the chat was that we need to make, to advance the agenda and of course build the political will to address the complexities of early childhood development. We need to focus on a few key areas. And to me, one that came out, you have to build on what exists, but you also have to understand the context in which you're working. And the key stakeholders have to own the systems change agenda themselves. And a comment here that community solutions usually are the ones that help that systems change happen. The second issue that stood out for me was the donors provide catalytic funding, but it's actually governments that provide money to scale up. So we need a shift from funding small boutique short-term projects to really shifting to funding long-term sustainable systems change programs, and be patient that systems take a long time to change. So we need the donors to hang in there for the long term and not just declare success because one small intervention happened. And I really liked the comment from my friend Gary that, you know, this linear reductionist approach, it does not work. And we know that it has not worked in many approaches, especially in the health sector, but in the education sector. And I think as we learned from Uganda, we need to build on government planning and financing itself, but then look at the subnational level on how you create the physical space at a district level, for example. And without that, systems change does not happen. The other issue that stood out for me was measurement of systems change, the careful consideration of appropriate indicators, which can give us comparative data. So we're not always comparing apples and oranges because the methodologies change and the theory behind that is always different. But also having that comparative data that can measure systems change, but also impact across different settings and across different systems. And I liked the comment about taking note of negative feedback loops so that we are continuously learning about what works, what doesn't, and that taking correction action. I think at the end of the day, we have to support adoption and implementation of systems based on solutions that work in particular contexts that are supported by the key stakeholders in a country. And as ECDAN is a learning platform, we hope to continue to elevate good practices and examples and create peer learning networks amongst us so that we can troubleshoot and understand the challenges and learn from each other. So this is just the beginning of many of these discussions. We will have many more webinars that focus and also create opportunities for learning. And then recognizing that systems take a long time, the importance of innovation. We must create an appetite for taking risks. And I would like to encourage donors to actually take risks with us. I would like us to continue to have the political will to challenge the situation as it is, but also take greater steps and risks and create the evidence that we need to share with governments that change can happen, systems change can happen, and governments can drive that change and it's not from external sources, but it's on internally. So I would like to thank our partners again from the Murdoch Children's Research Institute, the Harvard University, Sharon, Aisha, Kate, Jackie, who have embarked on this journey with us, our funder, Porticus Foundation, and also the ECDAN team, Shekufe, who has led this work, Brett, Hannah, and many others who have been behind this. To be continued. I'm very excited that we're having these discussions. So thanks everybody, and enjoy the rest of your days wherever you are.